Go.
A warm good evening to one and all. We cordially invite you to this Iasstd and AIDS 2022 Astinar program, which is on management challenges of discharges today. For this, I welcome our organizing secretary, Dr. Bhumesh Kumar Katakam, to start the proceedings. Over to sir.
Yeah, thank you, Dr. Kavita. So, on behalf of Iasstd, AIDS, Astinar, Asticon, we welcome all the faculty to this Astinar 3, the management challenges of vaginal discharge and urethral discharge. That is going to be held today, that is on 23 and 2022. So, the unique feature of this Astinar, it is a blend of academic as well as awareness on genital health and STIs and STDs. And not only that, the backbone for our academic activities is the postgraduates and SRs. So to sensitize and motivate them, the Astinar quiz will be there. For that, we will appreciation certificates and honors will be given. And those who will get maximum Astinar points, their HOD along with the faculty will be honored in the physical Asticon that is going to be held on 9th, 10th, 11th of September 2022 at Hyderabad Katria Hotel. And with this, I invite our organizing chairperson, Dr. G. Narasimharao Neta, to give welcome address. Sir, over to Dr. Narasimharao Neta. Neta, sir, you are muted. You unmute yourself. Neta, sir, you are...
Great. Very good evening to all. Respected Iasstd and AIDS President Dr. Murugan sir, General Secretary Dr. Mohan Kumar sir, Treasurer Dr. Chandra Shekhar Rao Garu, Organizing Secretary Dr. Bhumesh Kumar, my dear senior colleagues and my dear postgraduates. On behalf of Iasstd, it is my privilege to welcoming you all for this Iasstd Astinar 3 session is being held today. I should say heartful thanks to our faculty members who are involving in moderation and paneling the sessions and making us enlightened. I express gratitude Hetero Health Group for being part of the academic partner for this of Astinar CME sessions is being held regularly. At last but not least, I thank all our members who are participating and making this as a grand success. I humbly request senior members to encourage postgraduates to take membership and active participation in Astinar CME programs. I hope all will enjoy these panel discussions and quiz programs by actively participation. Thank you very much. The next, Dr. Bhumesh will take over and he will conduct the further proceedings. Thank you.
Thank you, sir. So without wasting any time, we will move on to the scientific session. For this, we invite the chairpersons of this Astinar 3, who needs no introduction. Dr. Sanjeev Vaishampayan, he was the past vice president of IADVL and is for more than 50 publications and various lectures at national, international levels. And he got the awards, ILDL Humanitarian Dermatology Award, Teacher for Excellence, and Dharma Seva Award, and orations at Dharmacon 17 and Iasstd 2014, Kutikan, Rajasthan, and needs more and more. Sir, please come on to the dais and occupy the chair, so physically and virtually. And the second chairperson, who needs no introduction, Dr. Manjunath Chennai. second chair. So he was the vice president, just immediate vice president of IADVL, and affiliation of professor and head of DVL Enapaya Medical College, Mangalore, and academic achievements. And to read more, and it will take almost more than 30 minutes. So he has various positions held at all the levels, at the state, national level. Sir, please come on to the dais and occupy the chair. And this Astinar 3 is yours, and over to chairpersons.
Thank you so much.
Good evening, all.
Yeah,
Start
moderator. Next slide, Srinivas.
To start with, I will thank the organizers that they have invited me along with Dr. Manjunath to preside over this important meeting of Astinar. See, the discharges of genital discharge or urethral discharge are very important aspects of the STIs, and they have to be deliberated nicely to train our PGs as well as the junior doctors. So I'm fortunate to introduce Dr. S. Kalaivani. She is qualified MD STD. She is presently director and professor of DVL Madras Medical College, very famous college for that. She has many publications, a lot of presentations too, a lot of awards and honors that she has been awarded. Silver Jubilee Oration of the Institute of Venerology, Esticon 2018, postgraduate teacher for 17 years and examiner for many, many years. She has area of interest being the focus of awareness of sexual health among adolescents. This is a very important topic. So I'll request Dr. Kalaivani to take over and start the deliberations now.
Thank you for your kind words, sir. Good evening to one and all. Kindly let me introduce our panelists first.
Yes, CV, Srinivas.
CV.
The PPT of Kalaivani. Yeah. Next.
Yeah, Dr. Krina Patel, who is professor and head of Department of Dermatology in GMS Medical College. She has served various posts in the National IADVL group, as well as her areas of interest are clinical dermatology, dermatopathology, and pediatric dermatology. The next one, Dr. Mahalakshmi. She is currently the professor and Unit 1 head of the department in OBG, Gandhi Medical College. She has been honored as Credential Indian Menopause Practitioner, and she has won the Abdul Kalam Educational Excellence Award by International Business Council, and she has also been awarded the COVID Warrior Awards from HRDA. Next one, Dr. Leelavati Madam. Presently, she is the professor and head dermatology in Bowring Medical College, Bangalore, and she is an editorial board member in Journal of Science and Education Publishing. She is a principal investigator in 25 clinical trials, and she has won Mahila Sri Ratna Award. The next one, yeah, Dr. Kavita. She is a consultant dermatologist, and she has got many publications for her name, and she has won IADVL Scholarship of 2016, and areas of interest are clinical dermatology, female genital dermososis, and lasers. Next one, Dr. Shika Bansal. She is a professor, Department of Dermatology from Vardhaman Mahavir Medical College in New Delhi, and she has got the VN Sehgal Award for Excellence in Dermatology for MD course. Her areas of interest are nail disorders and STDs. The next slide, we'll go to the session straightly. Next one. Yeah, this is the case scenario 1. 27-year-old married female presents with complaints of profuse foul-smelling yellowish discharge for the past 1 week associated with dysuria, dyspareunia, and vulval itching. History of lower abdominal pain present. Her menstrual cycles are regular. History of having unprotected sex 1 week back. Next slide. Next slide. Yeah, this is the, the previous one. This is the Speculum Examination, where you can see the profuse frothy yellowish white discharge using the bivalve self-retaining cusco-speculum. The next one. Video, please. That is a video. Please, video. See, you can see in the wet mount in normal saline, you can see the, yeah, you can see the pear-shaped organism with twitching motility. Yeah, the next one. So now I request Dr. Leelavati Madam to kindly join us. What is the likely diagnosis in this case? Dr. Leelavati, ma'am.
Yeah, hello, good evening.
Good evening.
Yeah, as per the speculum examination, the discharge is of variable color and it is frothy and varies from yellow to slightly greenish also. And there is a little bit of erythema on the vaginal walls, and you can also see punctate hemorrhages. It's classically called as strawberry cervix. There is cervical edema also. So this diagnosis is most favorably Trichomonas vaginalis.
Madam, what are the bedside investigation usually that can be done?
So the most commonly practiced bedside investigation is microscopy, that is wet mount microscopy. Though not a gold standard, but it is a quick and easy to perform, and it's of
With
low
one drop
cost.
of normal saline, we do the
Yeah.
wet mount and
should
look
be-
for the
The
trichomonas.
slide should be read within 10 minutes of collection of Trichomonas vaginalis, because it loses its motility quickly. And non-motile cells can't be diagnosed as Trichomonas. So the motility is one important aspect of diagnosis. So should be read within 10 minutes of the wet mount. And the molecular testing is also like the vaginal swabs can be collected for NAT, which has highest sensitivity of all the diagnostic methods, but it is not widely available, and cost being the factors which are not responsible for utilizing these tests so frequently. But most commonly practiced is microscopy, bedside microscopy.
Name the characteristic findings seen on cervix on speculum examination.
So cervix, here the cervix, there is a little bit of edema, and also you can see vaginal wall being erythematous. You can also see punctate hemorrhages.
So in trichomoniasis, you always see the colpitis macularis or flea-bitten cervix. What are the complications of trichomoniasis usually?
So complications can be in the female, then also in the male, in pregnant women. In female, it is pelvic inflammatory disease, and this lady also has pain abdomen. So that could be one possibility. Salpingitis, tubal infertility, and also there is higher risk for acquisition of HIV infection as well as transmission also. In pregnant women, if they have Trichomonas vaginalis infection, they can have preterm deliveries, premature rupture of membranes, or even low birth weight babies also. And in males, it can cause urethritis, prostatitis, epididymitis, also infertility.
What is the gold standard investigation used for diagnosis?
Gold standard is actually the culture, that is broth culture technique, that is the gold standard.
Next slide, please.
It has high sensitivity.
Next slide, please. Viru,
Next.
mention various culture medias available. Usually, what are the culture medias?
So actually, there is modified diamond medium, which has got peptone, cysteine, casein, and yeast extract. And there's also Kupferberg's SDS, and these are two commonly commercially available, which are ready to use, and also they are USA FDA approved. But the gold standard, as I said earlier, it is the broth culture technique.
What is the treatment for this patient?
So the normal treatment for Trichomonas vaginalis is metronidazole 2 grams stat dose, or even 500 milligrams can be given as BID dosage for a week, or tinidazole. It is also given in a dose of 2 grams single dose. And also partner management is very important here. And metronidazole 2 grams single dose can be given to the partner.
So epidose is important here. So sexual abstinence also you have to always advise.
Yes.
Okay. How will you treat metronidazole resistance?
So metronidazole resistance nowadays it is very, very common, and so usually metronidazole resistance cases you have to double the dose of the metronidazole, or in addition to the standard treatment you can also add on to the patient tinidazole, then vaginal creams also, clotrimazole also should be given to the patient, and or even you can give the treatment has to be continued for a long time.
Even tablet metronidazole 2 grams per day can be given for 5 days, or tablet metronidazole 3 grams per day for 14 days also can be tried.
Yeah.
Okay, thank you, ma'am. We'll move on to next case scenario. Yeah, 52-year-old married female came with complaints of thick, curdy white vaginal discharge for the past 5 days associated with external dysuria, vulval itching, and soreness. She has attained menopause 3 years back. She was a known diabetic on treatment with OHAs for the past 5 years. Next slide. Next slide, please. Yeah, the clinical examination, you could see the vulva, you could see the soreness, you could see the erosions and all, and speculum examination shows the curdy white discharge. So the next slide. So you can see in KOH mount, you could see, I won't describe, gram stain also you could see. So the next slide. Dr. Kavita ma'am, what is the likely diagnosis? Points in favor of diagnosis from this case scenario.
Looking at the curdy white discharge and the clinical picture with erosions and redness around the vulva, it is a typical candidiasis, and usually commonest cause of discharge seen in our practice. And other points in favor are the redness around the and the erosions, and occasionally we can see even edema around the vulval area. And the discharge, which is curdy, also described as cottage cheese type, and usually the discharge is scanty occasionally, and it is adherent also. And these are the features more in favor of candidiasis.
What
And
are
the
the
discharge is
predisposing
helpful to
factors?
differentiate from both trichomoniasis and the bacterial vaginosis also.
What are
The commonest predisposing factors in this case is diabetes, but other factors are prolonged antibiotic usage, on oral contraceptive pills, and in immunocompromised patients, and even in pregnant people. This is more, and on estrogen therapy, those who are estrogen therapy.
Okay. So what are the symptoms that has to be asked and signs that has to be examined in this case?
The common symptoms are, apart from pruritus vulva is the commonest presentation, and apart from that, dysuria, dyspareunia are also commonly seen. And the type of discharge, the duration of the discharge, and number of episodes the patient is getting per year. Are there any recurrences related to that? And relation to the menstrual history also related to before or after the cycles, is it common? These are the common things. And the drug history is more useful. Or there are any prolonged antibiotic usage in them, or they are using OCPs, which are usually precipitating factors. The history should be highlighted according to their symptoms. And the signs to be looked for are the redness, edema, which we already described. And apart from that, even the satellite lesions, the pustules and the satellite lesions, which are typical of candidiasis. And this is more useful to, signs are more useful to differentiate from commonest DD is from flexural psoriasis. And the satellite lesions, redness, and the pustules are more in favor of vulvovaginal candidiasis. And other things to be differentiated are contact dermatitis also, which can present in a similar manner.
Describe the findings in KOH mount and gram stain smear.
KOH mount, the typical thing we see is pseudohyphae. And these pseudohyphae can be differentiated by their, usually they are uniform in their diameter with notching in between. And gram stain smear, we can see the gram positive, okay, here.
Next slide, please. Yeah, what is the culture media used to confirm the diagnosis?
Seborrhoeids agar is used, and Neckerson's medium is commonly used.
What are the various topical and systemic agents used in the treatment?
The commonest treatment in the regular candidiasis, in uncomplicated candidiasis, azoles are the mainstay of treatment. Clotrimazole, miconazole, and even ketoconazole, the commonest topical agents which we used are these. And apart from that, we have terconazole and all these things. Topicals are more used in uncomplicated thing, but the oral fluconazole is the mainstay coming to the oral treatment, and the 150 mg stat dose can be used in uncomplicated cases. But coming to the complicated cases where fluconazole, a second dose after 72 hours is also to be given. And the topical treatment is to be prolonged from 7 days to up to 14 days, should be prolonged in case of resistant cases. And usually the common cause for resistance or prolonged treatment is non-candida albicans species are the more common cause for the resistance. In such cases, we have to change either the azole or we have to prolong the duration of the treatment. And apart from fluconazole, we can also use the itraconazole and ketoconazole. But while giving ketoconazole, we have to keep in mind the hepatotoxicity of the drug.
So management of recurrent vulvovaginal candidiasis.
Recurrent vulvovaginal candidiasis is once we see the candidiasis repeating more than 4 times a year, it is known as recurrent vulvovaginal. In such cases, as I have discussed, the treatment, topical treatment has to be prolonged for more than 2 weeks. And in some cases, the fluconazole treatment may need to continue for 6 months. Weekly once, 150 mg or 200 mg, depending on the dosage, it should be continued at least for 6 months. And along with that, long duration of itraconazole is also recommended. And the topical treatment should be continued for usually 3 to 6 months is the treatment in recurrent cases.
Yes,
and but in when it is not responding, then we need to give the intravaginal creams are also available. We can give in complicated or recurrent cases. Both clotrimazole and all the vaginal pessaries are available. They can be advised in both regular candidiasis or in recurrent vulvovaginal candidiasis.
Madam, can I add something?
Yes, ma'am.
Yeah, just I wanted to ask that, do you give itraconazole in a daily dose for a long time for recurrent or recalcitrant candidiasis?
Yes, ma'am. Now recently I am giving almost for 45 days itraconazole in a few cases.
Because
when there is recurrence.
I have also come across some cases where most of the cases they recover when I give them itraconazole initially for 7 days. And then I give them once 800 milligram. That is on the first day of their menstrual cycle. And then repeat it every month like that. And that is how, 200 milligram. And if required for 3 days in a month with first day of menstrual cycle. And most of the patients respond well within 6 weeks. 6 months.
Yes, that's so fine. But in
so the dose of the itraconazole may become little less when we give in such a manner.
Yes.
Because most of them are fluconazole resistant right now because most are not Candida albicans. They are all non-albicans which we come across. Yeah.
Alternate treatment necessary for this patient?
Not necessary, ma'am. Yeah. Not necessary in candidiasis.
Thank you, ma'am. Thank you for your valuable inputs.
Kalevani,
we move on to case scenario 3.
Kalevani, shall I add one thing?
Yeah.
Regarding the dysuria in candidiasis, especially this dysuria is not during the act of maturation, especially it will be last part of the dribbling, that is due to contact with the urine, last part of the urine. So this is called as vulval dysuria or urine dysuria. That is very important, not that's one. One more thing, the satellite lesions is more common with the skin lesions rather than the mucous membrane lesions. Thank you.
And another differentiating point in non-Candida albicans species, usually there is more of burning sensation, soreness are more described in case of non-Candida albicans than in Candida. That is one differentiating
mostly they
point.
are asymptomatic.
Yes, yes.
Okay. Can I add a word?
Yes, sir.
The recurrent candidiasis is treated as per the UK recommendations by the vaginal pessaries 6 days every month. Of course, you have to rule out iron deficiency, pre-diabetic state, obesity, and you have to tell them about the hygiene, keeping the areas open, no underwear at night. And all this has to go on because safety of all the drugs given, oral drugs given over long periods, we can avoid by giving only vaginal pessaries. These are the usual recommendations. And in some people, amphotericin pessaries are also available. Amphotericin creams are also available in resistant situations. You can have a simple choice of that as well.
Even boric acid pessaries are useful in non-candida.
Thank you.
Thank you, sir. One more thing regarding the recurrent vaginitis, we have to examine the partner also, Madam Kavita, Madam, and sometimes they may be a source. That's also a recurrent vaginitis. We have to look into that matter.
Always partner should be screened and.
But partner treatment is not necessary, sir. Examination is necessary.
Treatment not necessary, but recurrent we have to.
Yes.
Okay, thank you. Thank you for your valuable input, Dr. Bhushan Kumar sir and Dr. Murugan sir. We'll move on to next case scenario 3. 30-year-old married female presents with profuse vaginal discharge with fishy odor for the past 1 week. No history of vulval itching or soreness. Her menstrual cycles are regular. Her last marital contact was 2 weeks back and unprotected. Next slide. Biru, next slide. Yeah, the clinical examination, you could see the external genitalia, and then the speculum examination, you could see the discharge and you could see the cervix. Next one. Yeah, here you could see the wet mount in 1 drop of normal saline and the gram stain picture. The next one. Yeah, what is the likely diagnosis from this scenario? Dr. Krina Patel, madam, can you just join?
Yeah, so the diagnosis is quite obvious from all the features which are present, the classical features with the discharge, which is
the previous slide.
Yeah.
Viru, the previous slide. Yeah.
So the discharge, which is somewhat watery and shiny looking, the internal cervix and all the organs which look on per speculum examination because of the this adherent discharge, and the foul smelling which patient might be complaining on and off sometime, maybe after intercourse. So this all suggests the diagnosis as bacterial vaginosis. Even she has no symptoms and no other menstrual irregularities and nothing like that. So it mostly suggests a pure bacterial vaginosis. But here we need to rule out the other diagnosis whenever we are suspecting bacterial vaginosis, maybe a co-infection with other organisms or simply other trichomoniasis or any other infection. We should rule out first, and then only we can label it as pure bacterial vaginosis.
Mention the risk factors associated with this discharge.
Yeah, so this is not a per se a sexually transmitted infection. So it's not like exactly the partner may or may not be having the organism in the genitals. Like sometime you may find in urethra of the man, but mostly it is not. And even if we find in partner, it is not so that the partner has transmitted, but it is the altered vaginal pH due to any reason which might lead to this decrease in the normal endogenous lactobacilli, and then the overgrowth of the organisms which are causing bacterial vaginosis, chiefly Gardnerella, and associated with that maybe Mycoplasma hominis or Ureaplasma urealyticum.
Early age of first intercourse, vaginal douching. Okay.
Yeah, vaginal douching, and yes, using prolonged antibiotics. This all can predispose the patient to
what is the reason for fishy odor?
So the fishy odor is mainly because when the discharge comes into contact with any alkaline substance, then the putrid, the release of amines.
Previous slide.
Amines, yeah, from this discharge that lead to the fishy odor.
So the Production of
Yeah,
amines
so the
by
contact with, basically contact with the semen, during which the postcoital there is a fishy odor, and we can test that same with the KOH, adding the KOH in the discharge.
It's due to the production of amines.
Yeah, so the release of amines. Yeah.
Trimethylamine. Okay,
Yeah.
what is the diagnostic criteria used?
So mainly this is, as I said, it's a clinical diagnosis. So the MCEL criteria which are used. So the pH of the vagina, which becomes acidic, more than 4.5, it may be up to 6. Then clue cells which are present, as you have shown in your one of the slide on wet mount preparation, what we can see, that is one of the MCEL criteria. And then you have fouls, this odor, which fishy odor, which comes when the this comes into the contact with some alkaline substances, and the gray thin discharge, which is adherent to the vaginal walls. These are all the criteria which can be taken help of, and 3 out of 4, if they are present, we can diagnose as this bacterial vaginosis.
Positive whiff test also. So what are the other scoring systems that are used for the diagnosis?
Yeah, so the other scoring system is basically used to confirm the diagnosis and to know the severity. That is a Nugent score, where we can, by gram stain and calculating the score of lactobacilli, Gardnerella, and the other. And the other, by which, like, you can then calculate the score, and accordingly you can grade the severity of the disease.
The other scoring systems are Schmidt's scoring system and Hayes and Eisen.
Okay. Yeah.
Next slide, please. Okay, what are the investigations you will do for this patient?
So basically, the investigation is, the main investigation is identifying the clue cells. So you can do a wet preparation, or we can do the gram stain preparation, by which we can identify the clue cells. Culture is not going to be helpful, and even it is not going to be diagnostic here. pH is one which we can take help of. If pH is more than 4.5, that is almost diagnostic for bacterial vaginosis, with or without any other diagnosis. So these are basically main diagnostic tools. Then there are some point of care tests which are still not available in India, but maybe in near future they may be available, which are basically the same, that they give the pH and the this wet mount preparation. Both can be done at the same time within few minutes by a single test. With a good sensitivity and specificity. And the other are some DNA based tests, which are again this rapid test which can be done. So maybe in near future they might be available for us.
Describe clue cells and pseudo clue cells. So clue cells, how do they look like actually?
So the epidermal, these detached epidermal cells, which are covered by bacilli, their linings are obscured by the bacilli. And Gardnerella. So that is how the clue cell look like. And they will be profuse with less number of leukocytes. So that is the diagnostic feature for bacterial vaginosis. If there are more number of leukocytes along with the clue cell, we may have to look for the co-infection with Trichomoniasis, or co-infection with any other organism like chlamydia.
Pseudoclues cells, usually it is seen in cytolytic vaginosis, and usually the abundant lactobacilli cover the fragmented epithelial cells. So what are the complications of bacterial vaginosis?
So the complications are basically because the pH becomes acidic, there is more risk of transmission of co-infection. That is, the main is HIV, and the other STIs can get transmitted along with this infection. So that is the main risk. Then bacterial vaginosis, again during pregnancy, can lead to the complications like premature birth or a miscarriage in the mother. There is if it is long-standing untreated, it can lead to PID, can lead to even endometritis and salpingitis. And during a gynec surgery, there are some recommendations that patient before hysterectomy or other gynec procedure, patient should be treated for bacterial vaginosis if found. Otherwise, that can lead to the complications like PID and post-abortion infections in this female. And particularly this, rarely it can lead to bacteremia, but that's a very, very rare chance. Yes.
Will you treat this patient? Treatment?
Yeah, so treatment is again matronidazole, which is ideal treatment for the bacterial vaginosis. So matronidazole here can be given in the stat dose because this generally does not involve the, mostly if it is uncomplicated, it generally does not involve the other internal organs. So that is why a single dose matronidazole can be helpful to this patient.
Or metronidazole can be given in a BD dose.
Yeah, so secnidazole and tinidazole are also single dose therapy can be given, and in resistant cases it can be given for 7 days. Clindamycin is again one therapy which can be given for 300 milligram BD for 7 days.
Okay.
Yeah.
So topical also 2% clindamycin cream for 7 days or
Yeah.
0.75%.
Yes, topicals can be very helpful here in these patients.
So
yes.
recurrent bacterial vaginosis, how will you manage?
So for recurrent vaginosis, rather than a single dose, we need to give the treatment for 7 days. Mostly metronidazole 500 milligram BD for 7 days. Or if it is resistant to metronidazole, then if there is a recurrence after metronidazole, then clindamycin can be very, very helpful, because metronidazole may not have effect on Gardnerella vaginalis. So the other therapy like clindamycin can be given for such patients.
What's the relationship between bacterial vaginosis and HIV?
HIV, right?
Yeah.
Yeah. So the because it increases the pH of this vagina, there is a more chance of acquiring infection, and there are some other hypotheses also, like it increases the HIV target cells. So the transmitted HIV can directly enter into the target cell, and that is how it lead to the more chance of infection. Then there is some decreased endogenous antimicrobial activity because of low count of lactobacilli, which again predispose the person to transmission of co-infection with HIV.
There is increased intravaginal interleukin 10.
Interleukins, yes.
Susceptibility of the macrophages.
Yeah, so more immune mediators, which are soluble immune mediators, which can change.
Okay, thank you. Thank you for your input, madam. We'll move on to the next case. Next slide, please, Viru. Yeah, case scenario 4. 56-year-old married female.
Can I add a word, please?
Yeah.
The first thing is that bacterial vaginosis has been seen in young women without any sexual exposure.
Yes.
Second is the STI pathogens and HIV are not pH dependent. Their entry is not facilitated by the low pH. The only low pH additional problem can be Trichomonas vaginalis infection. And the others are, as you said rightly, it is the interleukin dependent, and also the inflammation of the mucosa, which invites more cells to the surface and which also allows the entry of the HIV into that.
Thank you, sir.
Thank you, sir.
Yeah. Let us move on to the case scenario 4. So 56-year-old married female came with the complaints of mucopurulent vaginal discharge for the past 1 month associated with dysuria, dyspareunia, lower abdomen pain, and post-coital bleeding. She was a multiparous woman and attained menopause 5 years back. Next slide. Yeah, per speculum shows the clinical picture. Next one. What is the likely diagnosis and points in favor of the diagnosis in the present scenario? Dr. Mahalakshmi ma'am, would you kindly give your...
Yeah, good evening, everyone. And at the outset, I want to thank the organizers for giving me this opportunity. Thanks a lot. And right, while looking at this itself, first of all, we will suspect first carcinoma only. First, unless we exclude that, we will not go into any other diagnosis. So first we have to think only in terms of the carcinoma cervix, but from the thing, whatever the secretions are there, unless we wipe it out, we may not be able to know whether it is a cervical erosion or only whether it is a hypertrophied cervix or whether there is any growth.
What additional history can we elicit in this patient, ma'am?
Yes, madam. Usually here the points in favor are the age is usually the commonest age of the carcinoma cervix is between 40 and 50 years, but it may move this side or that side also. And here multiparity is there, postcoital bleeding is there, and mucopurulent discharge is also there. And then we have to see whether it is associated with blood stain discharge or does it have any foul smelling. And then the next parameters, what we have to think are age at the marriage, which is very, very important, because if they are more prone, if they are exposed to the sexual work before 18 years, they are more prone for it. And then whether it is associated with blood staining or the parity, just it is mentioned that parity, multipara, but it is directly proportionate to the parity, the incidence. And age at the time of the first delivery, we have to take into consideration. And then history of any family history of malignancies, and whether she has any multiple partners. Of course, we cannot ask, but as a part of this, we have to include in that.
Madam, history of any cervical warts or in past might be important for such patients.
So yeah, maybe because of the HPV infections, but usually they will give rise to, before itself they will come up. Usually the carcinoma cervix, when we see that, definitely they will come out with that history and all, but usually very rarely we have seen like that actually.
What are the tests to be done to confirm the diagnosis, ma'am?
Madam, here, because we are able to see some growth, we can take directly the biopsy from that. But otherwise, if we don't see anything, then the picture comes into screening, like Pap Smear. The Pap Smear is the thing that is otherwise known as a surface biopsy. Usually, we will be taking from the squamocolumnar junction, that is the junction of the endocervix and ectocervix. Usually we will be taking the biopsy scrapings, we will be taking from the surface of the ectocervix as well as from the squamocolumnar junction as well as from the endocervical canal. And here there are two types are there. One is on the slide we will be taking, and then we will be immediately shifting into the fixative, which has the ethyl alcohol and ethanol equal percentage. And then it will be stained with the panicola, and then it will be seen. Otherwise, we will be doing it as the liquid-based cytology, which is supposed to have a more value. And then along with it, we will be sending for the HPV DNA testing also. That is human papillomavirus, because which is one of the commonest cause for the predisposing for the carcinoma cervix.
How will you interpret the findings of visual inspection with the Lugol's iodine screening at a PHC level and all?
Yes, madam. So there are two types are there: visual inspection with the acetic acid and visual inspection with the Lugol's iodine. Because usually with Lugol's iodine, what is the basis is, whenever the iodine is applied over the cervix, these cervical cells and vaginal cells, they have the starch in that, glycogen in that, because of the estrogens. So whenever a normal cell has this glycogen, it will turn into mahogany brown. Whenever the cancer cell is there, which doesn't have the glycogen, will not take up the stain, and it will be seen as it is. So whenever the stain is not there, we'll take into consideration that that is the region from where the biopsy can be taken. So the same thing with the visual inspection with the acetic acid also. The acetic acid, whenever there is acetovite areas, we call it. So wherever the malignant cells are there, they'll have the more nuclear material, that means which has more protein, that will go into dehydration because of the acetic acid. So from there, we will be taking the biopsy.
Thank you, ma'am. Thank you for your valuable inputs. Thank you, ma'am.
Thank you.
Yeah, we'll move on to the next case. So here,
Madam, sorry for the interruption again.
yes, sir.
We missed out on the lower abdominal pain, which you had mentioned in your this thing. And the second thing is age for that matter is no bar to getting a sexually transmitted infection. Because once you are talking about the kind of a discharge, there is no harm in making a simple gram stained smear. That should be, and because and most important thing is the duration of the symptoms. If this duration of the symptoms is just a few days or a week, then probably we have to think of something else, because malignancy will produce symptoms which are of a long duration. Thank you.
Always we have to rule out the STIs as well as, and then you have to go in.
Sir,
Thank you, sir.
first we have to rule out malignancy because that is the life-threatening problem. But usually it goes as part of that STDs also. But we always try to rule out first malignancy. Usually for all these cases, if there are no other lesion is visible, sir, first we will take, first we will treat the infection. Then after 1 week, we'll take the Pap Smear. Right. Okay, sir. Thanks a lot for that.
Thank you, sir.
Yes.
Case scenario 5. 28-year-old married female presents with mild vaginal discharge associated with itching for the past 1 week.
Srinivas, please mute Patnaik, sir. Satyadarshi Patnaik, please.
Yeah, thank you. So 28-year-old married female presents with mild vaginal discharge associated with itching for the past 1 week. History of premenstrual exacerbation present. The next one. Next slide. Yeah, Speculum Examination shows the clinical picture. Yeah, the next one. So what is the likely diagnosis from the scenario? Dr. Shika Bansal, could you kindly...
A very good evening to all, and big thanks to the organizers for giving me this opportunity. While preparing, I really learned so much. So as far as the diagnosis is concerned, since the patient had no associated itching and the symptomatology had premenstrual exacerbation and it was asymptomatic, so I would like to keep a diagnosis of just a simple physiological discharge in this patient.
What are the characteristics of normal vaginal discharge?
Most importantly, normal vaginal discharge in any patient will be asymptomatic. It will not be associated with any kind of itching, soreness, dysuria. And then we have to ask the patient in which phase of the menstrual cycle the patient is in. Is she in the ovulatory phase or in the luteal phase? So if she's in the ovulatory phase, then you expect the discharge to be little thin, little stretchy. In cases of luteal phase, the discharge will be yellowish. And mind you, the copiousness of the discharge, the amount also can vary from one person to the other. And just to add an important point here, now, what do you think the discharge is made of? It is made up of epithelial cells and the bacteria, which are secreted by the cervix and the vagina. So that is the normal vaginal discharge.
So the factors affecting normal vaginal discharge?
Mainly the normal vaginal discharge is under the hormonal influence, and in that the name which comes foremost in mind is estrogen, and then other oral contraceptives, then hormone replacement therapy, age of the patient, and then emotional stress, exercise, and sexual stimulation. All of them can lead to increased vaginal discharge.
Pregnancy also?
Yes, in pregnancy also the discharge is increased because there's increased blood flow mainly to the genital organs, and under the influence of hormones, the discharges is increased.
What are the physiological and pathological causes of vaginal discharge?
As far as physiological causes are concerned, as I said, it varies with age. So age is very important, whether the patient is pre-pubertal, pubertal, or menopausal, postmenopausal, pregnancy. So all these are the factors which affect. And I'm sorry, what was the question? The factors?
Physiological and pathological causes.
Okay, and in pathological, as we've already discussed, the candidiasis and bacterial vaginosis, and then Trichomoniasis vaginalis also. And otherwise, other causes can be foreign body insertion, for example, leftover tampons, etc., or vaginitis. These are the causes.
Pathological can always be classified as infective and non-infective. So infective vaginitis, we all know, and cervicitis, mycoplasma cervicitis due to gonorrhea and chlamydia, and non-infective can be due to foreign bodies, as you have already said, chemical irritants and gynecological conditions should be included.
Yes.
What is the management of this patient?
As far as management is concerned, most importantly, you have to counsel the patient that there is nothing wrong. The discharge can be normal and you don't have to do any active intervention. But at the same time, you take this opportunity to generally counsel the patient that you have to wash the area with mild, little lukewarm water, mild soap. But at the same time, the soap should not get inside the vagina so that it can cause vaginitis. You have to wear loose cotton underwear. And these are the general precautions which you tell the patient, and otherwise you just counsel the patient that nothing else needs to be done.
Yeah, patients should avoid ouching because most of the time they do this considering that vaginal hygiene is poor, and that then lead to bacterial vaginosis. So that's a very common problem. Nowadays, vaginal washes which are available, they frequently use it and then they'll end up with the bacterial vaginosis many a times.
Yeah, absolutely. These feminine sprays which are available, they also should be avoided. They can lead to vaginitis.
Conclude. So for any vaginal discharge case, you have to ask the history in detail, in chronological order, and any history of treatment taken for the present condition and the sexual history, right? The patient is married, means when was the last marital contact, any premarital contact, extramarital contact, any history of previous venereal disease, any then obstetric and menstrual and obstetric history, any medical history, medical illness, any history of drug intake, okay, any history of immunosuppression, everything you have to ask in detail. So history is very, very important. And next, the clinical examination. So everything should be done in a privacy and confidentiality in case of STI patients.
Madam, can I add one word, madam?
Yes, ma'am.
Yes, madam, because in so many gynec clinics, we will be seeing very younger patients who are after this white discharge. So number one is counseling, and number two is we have to give them the confidence that after excluding everything, we are assuring them. So always take this opportunity for the Pap smear. And then if it is normal, then we can give them assurance. And then we should tell them that at every for 1 year, every 3 years like that, if they have this Pap smear, then they can be, there will not be any fear of any diseases or anything. So that, because otherwise what is happening is if we are not giving them the assurance, they are resulting in the unnecessary hysterectomies, which is a burden to the society, giving rise to so many other postmenopausal problems.
So after clinical examination,
madam, it is very traumatic to suggest to a woman of 28 years that we are doing the Pap smear. Make sure you have done the colposcopy. Make sure you have done the acetovite test or the Lugol's iodine test or something else. Only when you are in serious doubt, then only please suggest this Pap smear. Otherwise,
usually Pap smear is a very easy thing rather than all the other things.
No, it is not the question of easy or difficult. Question is you are subjecting a woman, young woman of 28 years to a test to exclude malignancy. So that is the basic issue. You will scare that person.
It is recommended. It is recommended.
Okay.
More than 21 years.
No. It is not that it cannot happen at that age. I'm only saying that you should be very, very sure that you are really looking at something which is doubtful. That is what I was saying.
But that is our practice, sir. As a gynecologist, I said that is okay. If you people don't accept, doesn't matter.
No.
The thing is, no, sir. Why I am telling you this is, it is my practical experience. In my
fine. Agree.
So many youngsters undergoing hysterectomies and coming with so many problems. That's what I thought. Okay, let me use this opportunity to spread the message.
Thank you.
Okay, sir. If you don't accept, it doesn't matter.
No.
One more thing, madam. I want to add, not for this. The discharge in young women who are not sexually active is also common, especially with students, that we have to ask the history. Washing habits, that washing from back to front has to be avoided. They may not the things from the anus. So that is also has to be mentioned for the sake of PGs, especially in youngsters who are not.
Mainly adolescent girls, they are coming like that.
Thank you.
History also, always the partner history. Okay, partner should be screened, and if found to be positive for any STI, they have to be treated. Counseling is very important. Follow-up is very important. Complaints of the drug is very important. Then a word about syndromic management. So we give green kit for vaginal discharge syndrome, which consists of tablet secnidazole 2 gram statin, tablet fluconazole 150 milligram 1 stat. Okay. So in case of cervicitis, gray kit is given. Okay. Thank you. I thank all the panelists for their active participation, and especially Dr. Bhushan Kumar sir for his valuable input, and Dr. Murugan sir. And I thank the organizers for giving me this wonderful opportunity. I thank especially Dr. Bhumesh Kumar, who has been an instrumental and always an energetic person. Thank you, sir. Thank you so much.
Madam. So vaginal discharge in the pediatric age group for adults, do you have any difference or the same approach? Because in adolescent, so many cases.
See, nowadays you should always think about child sexual abuse also. It is on the rise. Okay, so we cannot take everything as a normal. So we have to have we have to have it in mind also, and we have to ask the history in the parent, as well as if it is a prepubertal girl also, you have to ask in privacy, and you have to examine properly.
Madam, I wanted to ask you about this lactobacillus vaccine.
Yeah.
Mahalakshmi, madam, do you use it in gynecology for Trichomoniasis vaginalis?
Pardon, madam?
Vaccine.
No, madam, we are not using.
Thank you, Dr. Bhumesh.
Mahalakshmi, madam, this is an interaction between the gynecologists as well as the STDs, only to spread the knowledge, and ultimate goal is to get the benefit to the patient. So that is our main motto. The interaction, unless until we discuss in detail, so we cannot come out with the patient. That's the main motto.
Yes, Dr. Bhumesh. Thanks a lot.
Yeah. Umesh, regarding the children and discharge, there are so many things we have to mention, but it's not the time. That is a vaginal mucosa is different from the adult, and acidity, the lactobacillus is not there. So many things that is a separate topic. It has a long time. That is a separate panel discussion necessary. So it is a lot of things are there with the children. We don't need not go for that now. Thank you, sir.
Thank you, sir, for giving us this opportunity.
Veeru, second moderator. So over to Dr. Manjunath, sir.
Thank you, Dr. Bhumesh.
Yeah, thank you.
Thank you, Dr. Madam Skalaivani, for wonderfully carrying this entire spectrum of the vaginal discharges, and it's been a wonderful learning for all of us. Thank you so much, and thank you Iasstd and AIDS for bringing this. Is it possible to mute that particular? Yeah, I think it's that. Yeah. And in the second half, we are going to deal with the urethral discharge in men. Urethral discharge in men still accounts for a fairly good number of STD as well as non-STD cases. I think this will be dealt in detail. So when I'm thinking of urethral discharge as a standard teaching, the medical college teaching as a professor, what we normally teach is the gonococcal and non-gonococcal urethritis. The gonococcal, one thing to be remembered about Neisseria gonorrhoeae specifically, also the CDC, test, it supports what I'm just going to say is that it's yet another bug in the making of superbug. We initially heard about the penicillin. During my postgraduate days, I was taught you give 48 lakh unit of benzyl or penicillin, procaine penicillin to treat. But then now the penicillin we don't even talk about. And then came the era of the quinolones, fluoroquinolones, and then now we are in the era of cephalosporins, and also there are reports of cephalosporin resistance. And if it gets rampant, we have a superbug in the making. That's an importance of Neisseria gonorrhoeae as a gonococcal urethritis. And when it comes to the non-gonococcal urethritis, what we primarily see is the chlamydial urethritis. If one is uncurable, this is incurable, which is likely to be. Of course, right now it may not be, but it could be. It has a potential to be. We have invisible infection. That means you can't see an organism causing it. You just look for an indirect evidence to diagnose. You see the cellular changes in culture, or you do certain NAT or PCR tests to detect. So you have two diverse etiologies here. And in addition, we do teach in the standard teaching the syndromic management. I'm sure all these things will be dealt in this particular session. And without much delay, I request Ilangovan sir, who is a professor in the Department of Dermatology at Kalambakam Hospital, and who has got a wide knowledge in this topic, will be taking over as the moderator of this session. Sir, kindly take over from here.
Thank you, sir.
Next slide.
Can I share my screen, please?
Yeah, you invite the panelists, sir, first.
Okay.
You invite the panelists.
Yeah. First panelist, Dr. JVDS Prasad, sir. He is from Tirupati.
No, Hyderabad. Now Tirupati.
MBBS and MD from Tirupati. Now he is at Hyderabad, Osmania Medical College. Second panelist, Dr. Hanumantappa from Mysore Medical College, former Dean and Director. Though I'm not going in details because of the shortage of time. I have 20 questions, please. Kindly excuse me. Next panelist will be Dilip Shah, sir, and he has finished his diploma and other things in London, and but he hasn't shown where he is working now. So fourth one is Swatlina Pradhan from Patna. Next one. Dr. N. Srinivas, the urologist, he'll be joining with us. So I'm going into the discussion straight away because I have 20 questions now. Can you allow me to
Srino, stop sharing.
PowerPoint, please?
Yeah, you go ahead, sir.
So I'm going to discuss not only urethral discharge. So point of interest, I'm going to talk about pharyngeal as well as anorectal discharges also. So I think you won't mind in that.
Yeah, go ahead, sir. Please put it in slide mode, sir.
Yes, sir. So is it okay now?
Yeah, put it in slide mode.
Management of challenges of urethral discharges in men, adult and children. So being the moderator, I am Dr. Ilangovan. Other panelists are Prasad, that we have already seen. And
slideshow mode, please.
Put it in slideshow mode, and it is not moving.
It is in slideshow mode.
Bottom right.
Is it okay now?
No, sir. You may reshare it once, so that that must be
sharing. I can reshare.
Yes.
Is it okay now?
No, sir. You may reshare. You can stop sharing. You just take the cursor to top. The panel will come down. Stop sharing and reshare. Yes.
Okay.
You put it in slide mode.
No. Yes, sir. That's right.
Is it okay now?
No, so it's not going for slideshow. There must be some technical problem.
Actually, once if you share, just to click on the share and whatever the PPT you open, you come down to the PPT, then it will work.
In that situation, and I think I have to request your people to upload.
Yeah, Srinivas, you go ahead with your PPT.
Yes, yes. I'll stop mine.
Okay, sir.
Yeah, you go ahead. The backup has worked. Yeah, go ahead. Next. Yeah, next.
Next slide, please.
Next, go ahead.
Next.
Yeah.
So as per the 2010 NACO data, among the Iasstd attendees, 34 were symptomatic. Among the male symptomatic, 50% were urethral discharge. So that is the higher level. Other things are the what and other things. Next slide, please. The recent data 2020 WHO says both chlamydia and gonorrhea is crossing around 200 million. That is more than half of 374 million of total infections. So there is a higher level of gonorrhea and chlamydia. So let us ask our first panelist, Dr. Prasad sir, about number of urethral discharge cases seen in our practice.
Sir, actually, I'm a faculty at Usmania Medical College in the Department of DVL, where we have separate STD clinic which runs 6 days a week. So we are seeing almost 15 to minimum of 15 and maximum of 35 cases per day, all STA cases, including non-STAs also, that who comes for the screening from referrals from ART center or ICTs. It's not a big surprise for us that we see on an average 1 to 3 cases of frank urethral discharge, which may be purulent or may not be purulent in men attending to our STD clinics. So we have got significant numbers, and the same phenomenon is seen among the high-risk group people who have been referred from the targeted intervention NGOs. We call it as a TA NGOs, who have come to us. There also we are seeing the good number of the.
While comparing previous years, 10 years now, it is increasing or decreasing?
Yeah, it is definitely. Definitely, sir. Say I'm there in Usmania since 2013. Since 2013, almost you can say that the cases are increasing in numbers.
Okay, sir. Okay, sir.
That's
right. So coming to the genital discharge in male, so it can be classified as superficial and urethral. So we are mainly concerned with the urethral discharge. Next slide, please. So the urethral discharge can be physiological and pathological. Dr. Hanumantappa is there?
Yes.
Yeah.
Hello.
Yes.
So have you come across the physiological causes of urethral discharge, which we have to find out so that people won't go for phobia? So kindly discuss about the physiological discharges.
Yeah, many people thank you, Dr. Ilangovan. Many people they come with these physiological discharges, thinking that they're pathological, they have some problems. Particularly like pro-semen. If they don't have the regular sexual intercourse, excessive semen is there, our sexual arousal can take place due to so many other provocative factors, and there will be semen leakage from the urethra, which makes them that this is an abnormal thing, and for that also they come. Then the second possible thing is hospituria. Hospituria usually avoid discharge without any asymptomatic, and that occurs before passing the urine. And before, another problem is spermaturia. So that usually occurs while passing urine, the sperm is passing, and the cloudy urine, they think that there is some problem with them, and that is a discharge that is going to produce problem. Then at the end of the micturition, they pass white discharge, and many people they say that that is prostituria. So the prostatic discharge, the seminal vesicle discharge combining together, they are discharged at the end of the micturition act. So these are the
second slide. Next slide, please. Sir, continue, sir. Continue, sir.
These are the physiological discharges. So suppose if there is any problem, so then you can check them. So either milking urethra, or if some people they bring the discharge also in some bottle, collecting in the bottle, they bring it. So we can do it if they bring it. And normally these discharges, when we investigate, simple investigation, the pus cells, they will be less than 5, not in clumps or groups. If they're more than 5, then we have to think of pathological causes.
Okay, sir. What's the advice you give? Any counseling?
Pardon?
Like that? What's the treatment you give, sir, for physiological?
For them, reassurance. That's all. Counseling, telling them you don't lose any energy by losing all these things. These are all normal things. They happen to everyone in their life. So don't worry and give the reassurance giving them.
Yeah, the reassurance is very essential to prevent venerophobia. Otherwise, they'll be thinking that they are suffering from STD.
Exactly.
Okay, sir. Okay, sir.
Okay,
Next slide, please. Thank you, sir. Yes,
now,
sir.
1 minute. That is regarding physiological. One more thing is constipation. On patient who is having regular constipation or chronic constipation, they may likely to have prostaturia. That is one thing. When you relieve when you relieve the constipation, the patient will be all right. That's also there.
Okay. Okay.
Exactly.
Sir. Right, sir.
Compressing over the prostate. Okay.
Thank you, sir. Right. So next slide, please. So coming to the pathological urethral discharge, it can be, we classify it as gonococcal and non-gonococcal. Next slide. The non-gonococcal can be a specific cause or non-specific causes. Mainly the specific cause is mainly due to chlamydial and non-chlamydial. Next slide. The non-chlamydial can be infectious or non-infectious. Can I ask Dilip Shah sir about the non-chlamydial urethritis he has come across, whether it is infectious or non-infectious?
Yes, which is a very common thing. And you have a chlamydial infections, which are non-chlamydial. In non-chlamydial infections, you have Uroplasma urolithecum, Trichomonas vaginalis, and then Mycoplasma genitalis, which is a very common thing what we see in non-chlamydial. As far as the bacterial infections are concerned, we have streptococcal, staphylococcal, Neisseria, meningitis, and then we have a viral like herpes simplex virus. As far as the non-infectious things are concerned, we have urethral strictures, we have foreign body, neoplastic, and catheter trauma. All these factors we have to consider. But the main thing is that infectious things, and you have to rule out Uroplasma urolithecum, Mycoplasma, and the mainly Trichomonas vaginalis, which is to treat Trichomonas vaginalis, it's a very tricky thing because I'll tell you some practical points. When you take a smear, you have to take it from the posterior fornix, otherwise you get the negative results. Another thing is that when you take the discharge on the slide, it has a typical fishy smell. What is fishy smell? It's not only fishy smell, it's a rotten fish. I'll tell you a very interesting thing where I worked in London Hospital with Professor Thin. What they used to do is that they used to take smears from 10 female, put it on the slide, and they used to ask us to smell it and diagnose Trichomonas vaginalis. And then you diagnose it with the smell and then you check it pathologically and it turns out to be a Trichomonas vaginalis, which is a very common thing to treat in female. So all these factors you have to consider when you talk about infectious things in non-chlamydial infections. It's easy to treat chlamydial infections because we have a diagnostic facilities and we have a proper treatment for that.
Okay, sir. Okay, next slide, please. Next slide. Yes, these are the causes of non-chlamydial, as he has already mentioned. Next slide. These are the non-infectious cause, traumatic, chemical, caffeine and alcohol has been added as a non-infectious cause of non-chlamydial urethritis. Next slide, please. So the clinical spectrum can be asymptomatic infections or symptomatic infections and local complications and disseminated gonococcal infections. Next. So this is the question.
Some disturbance is going on. Srinivas, some disturbance is there.
Somebody is disturbing. Yes.
Srinivas, you mute them. We request, other than the panel members and moderator, please keep it mute form.
This question to Sotilina, urethral discharge of this type after 3 days of exposure. So what will be the clinical diagnosis or how will you proceed further?
Looking at the type of discharge, it is looking like purulent discharge. And
Yes,
3 days after discharge, so most probable diagnosis is gonorrhea. So
That's
gonorrhea
okay.
can occur in the incubation period is 1 to 14 days, every 2 to 5 days. So it can occur. And apart from this, I will ask the history. So there will be severe burning micturition will be there. The patient will be symptomatic, the pain and burning. And sometimes the patient can have urgency, frequency of micturition also could be there. So I have to ask all these history. And
Okay. Next. So how will you proceed further? How will you confirm the diagnosis and proceed?
This is simple test is I can do a gram stain and see for gonococcal. Then after that, sir, if the facility is available, you can go for this one PCR or other lab facility, culture and etc. And I will treat with this first gray kit because urethral discharge that is suffixing 400 start and azithromycin 1 gram start. If you want to only this is for syndromic management. If you are not only targeting gonorrhea, then we can treat specific gonorrhea only with the suffixing 400 start dose.
Okay. Will you treat chlamydia along with gonococcal now in this patient?
Most of the time, STD is combined always. If one patient is having one STD, he might have other STD. So no harm in giving syndromic management to this patient, sir.
Yes. Okay. Right. Next slide, please. Next slide. Yes. So next slide, please. Next slide. So you have to treat with gonococcal, with the non-gonococcal, with the gray kit. This is a dictum. About 40 to 50% of gonococcal will have chlamydial infection. So always treat non-gonococcal along with gonococcal infections. If lab facilities are available, you can go for gram stain and look for pus cells and gonococci. And RPR and ELISA must rule out other syphilis and HIV. So azithromycin not available, you can go for doxycycline. If cefixime is not available, you can go for injection ceftriaxone. So all these things. So syndromic management plays a major role especially in urethral discharge, because confirming chlamydia will be very difficult in our setup. People who are having PCR, jolly well they can do that, but most of the hospitals won't have the facility. Better you go for syndromic treatment. Next slide, please. So the uncomplicated infection, you have to treat ceftriaxone 250, cefixime 400, and for this one, azithromycin, doxycycline for 7 days. Next slide, please.
Sir, shall I add one practical point here?
Yes, sir.
This non-specific urethritis, especially chlamydial and uroplasma urolithecum, though we say 7 days doxycycline, 100 milligram BD, the practical point is one can go up to 3 weeks if you really don't want the recurrence. That is what was.
No, that is another question is there. I think you can add to that. Persistent urethritis is there. Okay, we can add to that. Yes. Okay. There is another case having discharge. 10 days after exposure, he started developing the discharge. The discharge is like this. The question is to you, sir. Srinivas, sir, urologist.
Thank you, sir. Thank you, Dr. Bhumesh, Dr. Evanjan, sir. Sir, this is based upon the discharge duration or based upon the discharge nature, whether it is mucopurulent or purulent. We cannot differentiate whether it is a gonococcal or chlamydial. So this we have to keep in mind and straight away give a combined treatment, a gray kit, either a cefixime and azithromycin or ceftriaxone 250 milligrams and azithromycin. If azithromycin is not available, doxycycline, and then send for tests. Same, discussion is almost same as the previous case. Send for tests like gram staining. At this point of time, we have to remember, call back the patient after 3 to 5 days. If there is persistent symptoms, we have to keep in mind for other diseases like syphilis or adenovirus or urea mycoplasma or trichomonas.
Okay, sir. Okay. Next slide, please. So the same, similar, whatever the discharge is, whether it is mucoid, mucopurulent or purulent. So you think of gonococcal as well as non-gonococcal infection, treat syndromically, do the investigations. Next slide, please. So the question 5 to Prasad sir, patient complaining of only burning micturition without discharge. Okay. So how to proceed in this situation?
Sorry, when the patient male comes with the problem of only burning micturition, but when I don't see when the complaint is not the urethral discharge, then what we do with the patient, we'll milk the urethra of the patient to ensure whether truly the discharge is not present or not. And when the discharge is present, we treat for both gonococcal infection, chlamydial infection with kick number 1, which is grey color, sir. Whereas if the discharge is not seen, then we will ask the patient the sexual history in detail of the last 2 months or up to 3 months sexual history. If there is any risky sexual encounter is there in the past 2 to 3 months with an known or unknown person without protection, then once again we assume
continue with the next slide, please.
Yeah,
next
yes.
slide.
So we may treat the patient in the lines of gonorrhea and chlamydia only, with the assumption that this patient must have been an asymptomatic gonococcal and chlamydial infection. If there is no history of any exposure in the past 2 months or 3 months, no risky exposure, then we have to think of the non-STI conditions, which happens to be the dehydration and other bacterial or other non-STI conditions that are caused by the burning micturition.
Okay, sir. So if milking of the urethra is not giving any result, you can go for urethral smear.
Yes,
and,
that's true, sir.
Yeah, you can go for urinary sedimentation test and all.
Yes,
so if the lab facilities are available, you can go for it. Otherwise, syndromically, you can proceed like this.
That's true, sir.
Thank you, sir.
Ask the patient to hold the urine for 2 hours, and
2
then
hours,
you can
yes.
examine again. Yes.
Yes, sir.
One more thing regarding the burning micturition without discharge, we have to think of the chronic prostatitis, one thing. Another thing is very rarely a prodrome for herpes also sometimes manifests with burning sensation repeatedly. That's also there.
That happens mostly in asymptomatic release of herpes virus with the recurrent
Yes,
attack.
correct. That's correct.
Especially if the person.
So there is another question is coming that is about recurrence. Right. Next slide, please. Patient complaining of discharge on examination, urethral discharge as he has passed urine. As Bhushan Kumar has said, pointed out that we can wait for 2 hours and you can do that thing. And how to proceed here? So the question goes to Anumandappa sir.
Okay, thank you.
Next slide. Yes.
Actually, when patient complains of urethral discharge, but when he comes to us, there will be no discharge. Such patients we have seen plenty. And these patients usually, what happens, some of the patients, because of urgency of micturition of urethritis, they pass the urine and they come to the OPD. And what happens, the pus is washed up from the urethra. So we don't see discharge in those cases. And they complain. And we can ask them to wait for about an hour or so and come afterwards, so that inflammation of the urethra, they can come with the discharge. And we can ask, we can do milking of urethra and then take the smear. Suppose if there is no discharge at all, even before passing urine or withholding urine and coming to us, then we can, if the pus is there, give them treatment as already been mentioned, like cefixime and azithromycin combination, like 1 gram and 400 mg respectively. And if there is no discharge, ask them to come back after 7 days and see that full-blown picture of discharge is there or not. If nothing is there, once again, same thing happens, like counseling, reassurance of the patient, and telling him nothing to be worried about that. That's the thing we can do for such patients.
Okay, sir. Okay, sir. Thank you, sir. So any points to be added, sir? Next slide, please. Hello. Next slide. Here is our medical person who is complaining of urethral discharge for the past 1 year, in spite of taking so many antibiotics and all. He was going on showing this discharge. So it has happened more than 1 year. So the question goes to Dilip sir. So how to proceed if the urethral discharge is recurrent? Persistent, recurrent urethral discharge.
Hello. Can you hear me?
Yes, sir. Yes, sir.
Now, such cases are very interesting cases and the patients are frustrated. The first thing you have to ask is how promiscuous is this person? It's not only going from one consultant to other consultant and getting treated for discharge which is resistant, because if he is having in between sexual contacts and getting reinfected, then it's very difficult to treat such cases. Secondly, it is not only the reinfection, it is the recurrence. Maybe because the compliance was not done in the past with the proper treatment. The third thing you have to think about is treating the partner. Now, sexual partner could be wife or any other contact. Because if you don't treat the spouse or other contacts, then there is something called as a ping pong infection from wife to husband and husband to wife. All these factors first you have to rule out. Then you have a proper examination, milk the urethra. If you get a discharge, very good. Then you can rule out gonorrhea, you can rule out non-specific urethritis, you can rule out uroplasma, and then you can even think about trichomoniasis, all these factors. But if you don't get a discharge, then many times you have to treat these patients symptomatically. And then, as previous speaker said, that counseling also a very important part in this. Plus, you have to restrict his sexual activities, which is very important if the patient is coming for 1 year with recurrent discharge.
Yes, sir. Sorry, anybody adding points, sir? Our panel members?
Same
Okay,
thing
slide,
as Dilip
yes,
Shah
sir.
has nicely pointed out. Causes to nutshell like highly promiscuous individual and visiting many commercial sex workers and not getting treatment for the spouse and antibiotic resistance from the organisms and improper use of the medication. So all these things contributing for this.
Okay,
Assistant
thank you.
Compliance is very important.
Okay, next slide, please. Next slide. So patient with the tight phimosis, and he was complaining of urethral discharge, after which he developed the tight phimosis. So in this situation, how to treat the patient? So Dr. Swatlina.
Sir, here the patient is having two problems, that is phimosis and discharge. So we have to deal with the discharge like targeting both gonococcal and non-gonococcal, giving a syndromic management for that kit 1 gray kit. And regarding that phimosis part, most of the time we have to find out whether the patient, what is the cause of phimosis. The chronic candidiasis can lead to phimosis, and sometimes below that there is an ulcer or wart or something that leads to phimosis. You have to find out the cause of the phimosis. If it is chronic, if there is in phimosis, one thing point is there is edema is there or there is no edema. If there is edema, that is acute inflammation is there, you can give, I used to give 2 to 3 days short course of steroid to reduce the edema. So that if you reduce the edema, that will most of it opens. If it is chronic phimosis, then you have to go for this circumcision and dorsal flute.
Okay. So that's a difficult situation. And, if it is phimosed, we don't know whether it is to some other cause or it is due to gonococcal as such. So confirming other condition will be very difficult. So in this situation.
Sir,
right.
can I add a point?
Anybody? Yes,
sir.
sir.
Can I add a point?
Yes, sir.
Sir, this belanoposthitis patients come very common to us. We almost see 2 to 3 patients a week. The most underlying problem is diabetes. We have to look at
diabetes and candidiasis. Yes.
So majority of young people, 26 years, 30 years, come with severe angry looking prepuce. So who are not known.
The question is the person was telling that he had urethral discharge.
Yes.
And after that, he developed phimosis. That's the thing. Because worried about urethral discharge now. So we are not going to discuss about superficial discharge.
No, please. Because the thing is that if the word is used as urethral discharge, so you have to pull back the prepuce and make sure that it is not subprepucial discharge and it is only urethral discharge. So that distinction has to be made in the very beginning.
Yes, sir. So since it is tight phimosis, pulling back is very difficult, sir. So finding the urethra will be difficult.
Yes, sir. Without phimosis also, personal hygiene is very important because the smegma collection which is there, which they don't clean, sometimes they say that is a discharge. And very rightly, as you said, that you retract the skin and check it whether it is smegma or really it is a urethral discharge. You have to rule out these two things.
One more thing we can do, the subreptial discharge is usually anaerobic organism, and it will be offensive. It will have offensive smell, whereas the gonococcal discharge will not have smell. Moreover, the anaerobic discharge will be slightly frothy in nature. That's also will give a clue whether we are dealing with a subreptial discharge or urethral discharge. That's good.
Okay, can I add once again one point?
Yes, sir.
Moderator, sir.
Yes, sir. Yes, please.
Normally, such cases when they come, I have done majority of the cases subperficial saline irrigation.
Saline irrigation, yes.
Saline irrigation. And because of giving so many drugs like ulcers, warts, candidiasis, smegma induced. So what we can go? So best is in Dasas slit also cannot be done immediately. So I will go for that. Majority 90% we can get rid of, patient can get rid of that complete tight phimosis by doing saline subperficial irrigations. In some 10 to 15% of the cases, we have to go for dorsal slit or circumcision.
Okay, sir. Thank you, sir. Okay. So next slide, please. So question goes to Srinivas, sir. Whether the treatment you prefer syndromic or etiological in urethral discharge syndrome?
So we generally prefer a syndromic treatment for the first presentation. So when the patient presents first, we cannot waste time and wait for cultures, because treatment can lead to complications. So first we start a syndromic treatment. The syndromic treatment comprises of giving the drugs which are pertaining as per WHO recommendation based on the organisms that are prevalent in that geographic area. So for our areas, we give first gonococcal and chlamydial treatment. And along with syndromic treatment, along with drugs, we should give patient education, treatment of the partners, and condom distribution. These three things have to be done along with the treatment. And if the patient doesn't respond, we should reserve for the other investigations.
Okay, sir. Okay, sir. Next slide, please. So what about partner treatment in urethral discharge syndrome? So the question goes to Prasad, sir.
Yes. So the partner treatment is one of the mainstay in the treatment of the STIs, where if the partner is not treated at the right time with the right antibiotics, then the reinfection is a possibility, and we call it as a ping pong infection. And persistence of the discharge is seen for many months and years. The previous case, what we have studied, almost for urethral discharge persisting for 1 year. So partner treatment here, it includes the managing the all sexual partners within the last 2 months, and treating all the partners with the same treatment that what we are giving to the patient. If the patient is not sensitive for the drugs, what we are prescribing. So still kit number 1 is advised for all the sexual partners with our index patient in the past 60 days. The kit 1, which is gray, consisting of 2 drugs, cefixime 400 milligrams and azithromycin 1 gram. So when it comes to the partner treatment, I would like to add one more thing for the syndromic case management. It is the concept of the WHO, which was adopted by the government of India, sir. For our people's sake, just I am giving this explanation. Whereas the coloring of the kits, the grouping of the tablets and coloring of the kits is done by the project of the NACO. We call it as a KHPT project, the Karnataka Health Promotion Trust project, which was supported by the JHU way back in the year 2006 to 2008. So based on their experience, the NACO adapted the color coding concept, and they made these 7 types of the color coded kits, which is easy for implementing at the all levels of healthcare, from PHC to the medical college.
Okay. Okay, sir. Thank you, sir. Next slide, please. So what is the role of prosthetic massage? So Dr. Anumandappa, sir.
Thank you.
What is the role of prosthetic massage?
Role of prosthetic massage, one is for therapeutic, diagnostic aspect. Second one is therapeutic aspect. So after me telling, Dr. Srinivas, urologist, will add to that, I think so. Okay, anyway, diagnostic prosthetic fluid has to be taken, subjected for gram stain, and see for pus cells. It indicates prosthetic infection. And we can also look for gonorrhea by doing gram stain. And regarding therapeutic, it is much useful in benign prostatic enlargement, which reduces the frequency of micturition by doing prosthetic massage. And also it improves the erectile dysfunction and premature ejaculation patients who are complaining with benign prostatic enlargement. These are the advantages of prostatic massage.
So especially it is contraindicated in the acute stage because of the dissemination of the infection. So it is applicable only in the chronic infection where you won't be able to diagnose. In that situation, you can go for chronic urethritis and chronic prostatitis. This prostatic massage can be done. Even we have demonstrated trichomonas from the prostatic fluid.
Exactly.
So we have demonstrated at Madras Medical College. So it happens. We have diagnosed trichomonas from the prostate. Anybody adding any points?
Yes, sir. This is Dr. Prasad. Would like to add one point here.
Yes.
Sir, once we have done the prostatic massage, when there is no contraindication, what we observed is even the drug concentration achieving the prostatic tissue is also very high, and that is giving some relief to the patient from the prostatitis.
Yeah, that is applicable for chronic prostatitis, where
yes,
we do every month we used to do that.
Yes. Yes.
We can do that. Right. Yes. Okay. Anybody, sir? Okay, next slide, please. So, role of gonococcal culture and PCR. So, question goes to Dilip, sir.
Well, these days, it's very important to go for a culture and sensitivity because of recurrent infections. Normally, gonococcal, we go for a gram stain, that is okay. But then the culture, if you want to do, you can go for a chocolate agar media. But what is important here is going for a PCR or NAT test, which is a nucleic acid amplification test, which has almost 98% to 100% sensitivity and the correct results. Thing is that such tests are not freely available in all the institutions. But then one can always go for these tests to decide about the line of treatment. Once you are, it takes around 7 days for the test to show positive results, but then the positivity is almost 98 to 100%. So you can pinch the diagnosis.
Okay, sir. Thank you. So next slide, please. So role of procaine penicillin in treating urethral discharge syndrome, especially gonococcal. So Swatlina, Dr. Swatlina, please.
Sir, it can be given to that it's penicillin producing and gonorrhea in that case only, because.
So because procaine penicillin, previously we used to give 24 lakhs and 48 lakhs. After that, it has developed a resistance because of penicillin is producing Neisseria gonorrhea. So nowadays we are not giving procaine penicillin. So once for all, we have stopped. So any comments from anybody? Still people are using procaine penicillin or not? Murugan sir?
No.
You are muted, sir. Murugan sir, you are muted. Unmute yourself.
Yes, we are not using procaine penicillin. Moreover, procaine penicillin availability is also very, very difficult. So there is no role.
There's no role, in treating
at present.
Yes, sir. Thank you, sir. Next slide, please. So the complications regarding gonococcal and non-gonococcal infections. So Srinivas, sir, whether in your practice, whether you have come across any complications due to urethritis, due to gonococcal or non-gonococcal?
Most common complication that we see is the urethral stricture with gonococcal. That incidence was also high previously, but now of late, the gonococcal stricture incidence has come down because of effective treatments available. But other complications like prostatitis, epididymitis are known. And in females, it is again PID and infertility. And rarely disseminated gonococcus, which can lead to life-threatening complications like endocarditis also.
Okay.
And stricture with water can perineum that we used to see about 20 years ago, but of late water can perineums and all very less we are seeing. So maybe one case in a year. Like
that. Okay. Thank you, sir. Next slide.
Sir, shall I add one more point? One of the major complications what we see with these urethritis patients is erectile dysfunction. They are scared because of the pain and the itchy feeling inside the urethra.
Okay. So next slide, please. So this is the patient for whom we have given ceftriaxone after diagnosing gonococcal urethritis. He came back on the 4th day after treatment with the opening there and urethral fistula. So after 4th day of injection, so follow-up is a must. And we thought that Ceftriaxone might have cured the patient, but he came with the fistula. So let us ask our urologist, Srinivas sir, regarding this. How far it is common and what are the things to be done?
Actually, glandular fistula is not a very common occurrence of gonococcal urethritis, sir. But in this situation, first we have to do a culture, make sure that the infection has subsided, then only go for surgery, sir, fistula closure surgery. Okay. But without controlling the infection, if you go for early fistula surgery, it is deemed to fail. It will recur. Okay. That is the most important point we have to remember.
Okay, sir.
One more thing, we have to remember that paraurethral ducts opening will be there. Sometimes may be missed in the first inspection finding. It may be infected commonly because of columnar epithelium, more vulnerable for infection. That we have to remember paraurethral ducts, paraurethral opening. That's also there.
Okay. Okay, sir. Thank you. Next slide, please. So for interest sake, I have projected this. It's a case of pharyngitis. He had cunnilingus contact. 3 days of the contact, he developed pharyngitis with lymphadenitis, pain and all, severe pain. And I have taken the smear and I have demonstrated the organism. The little discharge there on the left side of the patient, you can see that. And so over to Prasad sir regarding pharyngitis. Even though we are dealing with urethritis, I thought it would be interesting. That's why I projected this slide.
So this is the
sir?
Yes, yes. So the changing sexual practices are one thing contributing for more of a gonococcal infection in the oral cavity, sir. Okay. As we call gonococcal pharyngitis. So it is not only limited to the male; it also limited seen in the female also in a female sex worker community, where they are if the time is not permits them to have a penetrative sex, they are practicing the oral sex on their clients, and they are we are seeing good number of the cases of gonococcal pharyngitis in our clinical OPD. So in this case, what we treat the patient is in the lines of the gonococcal chlamydia. For gonococcal, we give those cefixime is better drug as far as the NACO. We give kit number 1 only, but we don't have any treatment non-responding cases with kit number 1. But still, if the patient is not responding for kit number 1, then whatever the treatment that is shown on the screen, like Ceftriaxone for 100 milligrams and doxycycline, a combination of 100 milligrams BID for 10 days. I think these are the better options. But kit number 1 is available in the clinical practice or in the government hospital. It is better to give kit number 1. And if that patient is not responding with kit number 1, then going for alternate is better.
Okay, sir. Okay. Next slide, please. So anorectal discharge, it is. So regarding that, Anumandappa sir, can you add few points? I think we are running short of time.
Okay, I will very brief. So commonly it is seen in homosexual men, what we call catamite, men having sex with men. It's commonly seen there. Occasional mode of transmission like contaminated, gonococcal contaminated thermometers, rectal thermometers, and gloves, proctoscope, and enema nozzles. Most of the cases are asymptomatic, and only about 5 to 10% of the cases will show like irritation, pain, and discharge, and seropurulent discharge from that discharge also. And these patients has to be treated. Usually they are gonococcal or chlamydial origin. Maybe other organisms, non-chlamydial infections can also contribute. Along with the ceftriaxone, as usual, gray tablet like syndromic approach, azithromycin, 401 gram, followed by 100 mg BD doxycycline for about 7 to 10 days. So this is a line of treatment for that.
Okay, sir. Right, sir. Next slide, please.
Anorectal discharge, not only MSM, but sometimes it may occur even for the heterosexual women also.
Yes, wonderful.
I said commonly seen. I did not say it is only seen.
Yes.
Sir, Dr. Prasad, may I add one thing, sir?
Yes, sir.
Yeah, it's for anorectal discharge, need not always have a sexual intercourse with genitourinary activity. Sir, even the dribbling of the gonococcal secretions from the vagina into
that's what he mentioned.
Yes, yes.
Murugan, he mentioned.
No. Murugan did not mention that dribbling.
Yes, I told only anal sex with the women.
Yes, anal sex.
It is also possible. Yes, correct. That's correct.
Yes.
It's the auto-flow of the cervix to the anal canal because of the close approximity and auto-inhalation.
Yes, sir.
That is, Dr. Prasad, that is possible only when the infection is multiple infection, the combination infection is actually gonococcal infection will not be so copious. When it is associated with some other infection, that will be copious. Along with that, it can dribble and cause anal infection, anorectal infection. That is a possibility.
Yes, sir. Next one is sharing of the sex toys from the genital area to the perineal area is also one contributing factor for the transmission of infections.
So coming to discharge in children, and Dilip Shastra. So
it's real agony.
Common.
Yeah, it's very common. It's real agony for a child, and when you see the patients, really the child is in pain. Usually uncomplicated gonococcal vulvovaginitis, cervicitis.
No, we are talking about male children.
Yes, okay. In male children also you get urethritis, pharyngitis, proctitis. All these children, what you see the discharge, usually treated, if they are less than 45 kilograms of weight, then one can start treating them with a cefotaxime 25 to 50 milligram per kilogram body weight, but not exceeding 250 milligrams intramuscular or IV. That is the line of treatment. Children, those who are above 45 kgs, you can treat them like an adult. So you can use a cefotaxime 500 milligram intramuscular stat dose, or one can go for gentamicin or cephalosporin or azithromycin 2 gram stat dose. This line of treatment will help them. It's not only discharge from there, but also to prevent neonatal ophthalmia neonatal in kids. As a preventive treatment, you can use erythromycin eye drops. And if there is ophthalmia neonatal, you can use cefotaxime 25 to 50 milligram per kilogram body weight, intramuscular or IV, which will treat them properly.
So the cause may be a sexual assault or some other cause, prepubertal?
Yes. In many cases, there is definitely a sexual assault. Plus, the infection through, as they said that, the discharges lingering through linen clothes, which is active discharge, not the dried up, and they can land into that.
Okay.
Urethral discharge in children is very rare. It is the pharyngeal infection because of the sexual abuse, and also the anorectal.
Anorectal.
That is
Other than the sexual abuse, sometimes children they play with so many chemicals.
Yes. So usually
they introduce foreign bodies
and foreign body.
They introduce some chemicals like detergents or soap powder, and even trauma also. Just like in adults, you see, it can contribute for urethritis.
Okay. Next slide, please. 2 more slides.
Sickness, always if you diagnose, you should go with per kg body weight. For example, if it is azithromycin, 10 to 15 mg per kg per day single dose. Whereas if it is cefixime, 10 mg per kg per day, it should be divided in 2 doses. If it is cephalosporin, we can go to up to 100 mg in 3 divided doses. Only in a CNS infection, they will go to up to 300 mg. So per kg body weight, unless until you give per kg body weight, the response will be inadequate. If you give less, no response. If you give high, the side effects.
Okay, sir. So regarding follow-up after treatment of urethral discharge syndrome. So the question goes to Swatlin.
Sir, as we are doing a syndromic management to most of the patients, we are treating the patient on same day. So we have to follow up after minimum at least 1 week. After 1 week of treatment to see whether there is the discharge is still persisting or not. So again, weekly follow-up, and if it is still persisting after around 2 weeks, then we can go for the persistent discharge treatment. We can go for, and simultaneously regarding the partner also, we should follow up with the partner of the patient to whom he is in contact with. So both patient and partner follow-up should be there.
Okay. Anybody any points? So you have to rule out other STDs. So yeah, you have to follow the patient for another 3 months. Rule out syphilis and HIV. So that is a must. Even though it is for gonococcal, you are following for 1 week. So 3 months follow-up must be there because he might have acquired syphilis or HIV by the while acquiring gonococcal infection.
Apart from that, we will talk about the HPV, human papillomavirus spots, and then you have molluscum contagiosum, which has a longer incubation period. So all these cases.
So we won't be doing that test. We will be looking clinically, and we have to inform him whether we are developing any problem. You come over.
Yes,
but
correct.
Here we have to definitely you have to do the investigation, RPR and ELISA for HIV after 3 months. Yeah, so that's okay.
Because
So, next slide, please.
we have the friend from UK now. There the practice was initially, I do not know now, after 3 days, because if it is a single dose treatment, the organisms are supposed to be killed in the next 24 to 36 hours. So we used to examine the patient after 3 days for the subsidence of the system. The total discharge may not disappear, and the point of the care test can also be used at that time. But then the second follow-up is after a week, and the third after 2 weeks.
Shall I add one more point? Since you talked about the UK, they had a very advanced system of flying squad. I mean, the patient will give you the house number in Piccadilly where he had a sexual contact, and from the hospital they will send the flying squad to that lady, and then they will treat the contact there, which brought down the incidence of STD like anything in UK.
Yeah. Oh. Great. Great.
Contact tracing is so quick.
So big, yes, flying squad. And it was a fun to visit those places.
Okay. Right. Last slide, please.
No, one more point. If that is the case in syphilis particularly, early acquired, after treatment with penicillin, what we get a regular schedule. So it has to follow up like once in a month for first 3 months, once in 3 months for another 1 year, and once in 6 months for next 2 years.
Second year, yes.
Now at the end of second year, we have to do lumbar puncture, then VDRL, other serological test for syphilis. Then we have to declare whether patient is completely cured or not. As Stokes' definition, we cannot say the syphilis is completely completely cured.
It's very difficult to say whether syphilis is completely cured, because
Trichomoniasis
pallidum hemagglutination test, it remains positive throughout the life.
Once they're positive,
that stigma is always there.
Once they're positive, they are positive throughout.
Let's not go to the syphilis part, because the recommendations
follow for you.
Yes, people are Swiss is waiting after this. The last question is resistant to drugs, because CDC guidelines, recent guidelines says, so you have to switch over ceftriaxone 250 to 500, cefixime 400 to 800 milligram. And we are not going to give procaine penicillin because they already developed resistance. We can't give ciproflox. There are so many things, resistant, and so we won't be giving that to gonococcal infection. So the question goes to Srinivas sir regarding resistant to drugs. The last question.
Yeah, we are seeing a lot of drug-resistant variants, probably because of inadequate dosing or overusage of drugs, and the resistance is either chromosomally mediated or penicillinase mediated. And the choice is coming down, as we have seen now. Penicillins have gone, now cephalosporins are also going, and maybe we are getting very limited options like spectinomycin or erythromycin. So we have to be very judicious in usage, and proper dosing has to be given.
Yes, anybody adding any points?
Spectinomycin is not available anywhere in the world now. Spectinomycin is not available.
Spectinomycin 2 grams stat dose we used to give in 1983.
Yes.
Now it's not.
Next slide, please.
We can use kanamycin 2 grams.
Next slide. Next slide. So this is a new guideline by CDC. They have increased the dosage. That is ceftriaxone 500 milligram single dose, and so cefixime also increased to 800 milligrams.
Yes.
So we are going to increase the dosage like that. So we are going to develop resistance or not? We don't know. The future will answer us. So next slide, please. Next slide. So I thank everybody, the organizers, the panelists, and all the delegates here for giving this opportunity to share our knowledge and all. I thank once again Kadagam sir. So thanks to our President Murugan sir, Bhushan sir, and everyone here. Thank you all. Thank you so much.
I should say thank you to the moderator. Excellent moderation for this panel discussion.
Thank you, sir. Thank you. Thank
also,
you,
I
sir.
say thank you to Bhumesh for giving me this honor to
Quizmaster.
The panel. Thank you, Bhumesh.
Thank you, sir. Quizmaster slide.
Okay, sir. Bye.
Srinivas, Quizmaster slide. Yeah. Vaishampayan, sir.
Yes. Hello.
Yeah. Sir, go ahead.
Good evening again. Back to introduce Dr. K. Sai Krishna. Quiz is a very difficult problem. All of us, when we go to listen to the quiz, sometimes we feel that we don't know anything. So let us see how Dr. Sai Krishna handles this quiz and lets us know many new things. He is MD Consultant Dermatologist of Yashoda Hospital, Secunderabad. So Dr. K. Sai Krishna, please.
Good evening, all. So I thank the organizers for giving this opportunity, and especially Dr. Bhumesh, who was persistent, and he made me the quiz master. As you told, sir, quiz is a bit difficult. So let us see.
Instructions.
Yeah. So the instructions, slide please. See, there will be 22 MCQ questions. You'll have to answer them all. There's 1 mark for every correct answer. There is no negative marking. Duration of time is allotted is 11 minutes. First 2 toppers will be selected from PGs and SRs. And of course, my decision will be final. Thank you. We can go ahead with the quiz, please.
Yeah, Srinivas, release the question keys to the PGs and over to Manjuna sir to invite the Astinar star to give the skin health awareness, the genital health awareness. Today, Astinar sir is Dr. Murugan. Yeah.
Murugan sir needs no introduction, and I think the topic which has been chosen is extremely apt for all of us, indeed. Both the, I think, the general public and doctors community as well. So over to you, sir.
Thank you. Thank you, sir, for introduction. Please stop share. I will share. Yes, thank you. Thank you, Dr. Bhumesh and Dr. Neta sir, for giving me this opportunity to share my view. And as Bhumesh rightly sensitized this genital health with the words, he said that is the tragedy in the bedroom. It's more dangerous, more unbearable even than the earthquake, like that. It's true. It is true. Nothing exaggeration. Today, I'm going to talk something about sexual health. Speak the unspoken. The sexual urge is an instinct like that of hunger, thirst, or nature's call. Nobody can overlook. And sexual activity is the basement for procreation, propagation of species for every living things of this earth. The sexual health is defined by WHO as it is a state of physical, emotional, mental, and social well-being in relation to the sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationship, as well as the possibility of having pleasurable and safe experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. To reach the goal of procreation, it needs a platform for human beings, that is marriage, safer than living together or an casual encounter. Trust is the soul of relationship, can be attained through the legal marriage and love thereafter. Nowadays, it's not uncommon to see men are getting married in the late 30s, women are getting also married after 30s. Women's reproductive lifespan is comparatively shorter. However much you earn, however much you are owning and however much you pay, you cannot regain your youth, period. So don't miss the bus. Umpteen number of reasons may be sorted out for the delay in marriage, like studies, job, settling in life, and siblings to get married, etc. But all these problems were existing even the previous century also. Rather, family size were larger than olden days, but they got married earlier. Fertility rates also will come down after the age of 35. Fetal anomalies, complications of pregnancies, bleeding, delay in delivery due to lax uterus, fetal and maternal loss, etc. can occur with the late marriage. So it will be better that men have to marry before the age of 28 and women have to get married before the age of 26. That will be an ideal thing. We have to keep it in mind. We have to propagate. We have to make a propaganda as a sexual transmitted specialist, sexual transmitted infection specialist. This can avoid so many unwanted complications and retain good fertility rate and youthful love life. Preservation of youth, enjoying more intimacy, can care their children and groom them, education, get married, seeing the grandchildren, etc. before the couple's dusk of age. Myths and misconception. Why? Sex is a subject often neglected to be discussed both in schools and houses. Our society considers sex is a taboo. Parents and teachers hesitate to talk about the genital problems. It is not included in the curriculum either in schools or colleges about this important human function. Even the medical colleges, there is no separate specialty for the sexual medicine. Less talked in the medical undergraduate curriculum. Secrecy leads to ignorance and evokes the curiosity to know more. Because of this lacunae, a lot of myths and misconceptions about sex, sexual diseases, and reproductive tract infections and diseases are prevailing in the society. This situation is taken advantageous by the quacks. They propagate false information in the society through media, and this adds fuel to fire, and that is existing. The misconception is being reinforced in the society, in the men, in the human beings. Nowadays, lots of porn sites are also available on them online, make the situation worse. Youngsters seek Google for their clarification and get more confused. End results, fear, anxiety, guilt, depression lead to poor esteem among themselves, sexual dysfunctions, conflicts between couples, unconsummated marriage, marital disharmony, divorce, venerophobia and HIV phobia, suicidal tendencies and suicides. Some of the misconceptions about STI, HIV I mentioned, but I am not going to talk about in detail because it will take a separate 2 hours. Sex with a virgin causes STI, cures STI. Sex with animals cures STI. Sex with virgin more pleasurable. No symptoms, no STI. All STIs are curable, or sometimes all STIs are incurable. All these things are prevailing in society. Using public toilets will lead to STI and HIV. Purity and menstruation, sex during menstruation, signs of virginity, myths about breast size in women, genital size in men, semen not to be wasted and considered to be precious, and homosexuality is unnatural. Anal contact is free from STI, but actually is worse. Vasectomy will be end of sexual life. Marriage could be the solution for many psychiatric problems. That's also prevailing in the society. People with STI and HIV are untouchables. So all these misconceptions are prevailing. We have to clear it from the minds. And no curriculum about the sex education, and either in patients, either in schools or colleges, parents and teachers are hesitant to talk about these matters to their children due to the barrier in the name of culture. Misconception imbibed from the illicit source like friends, internet, peers, porn, etc. Sex considered as a taboo or sin. Orthodox bringing up all results in various types of problems. So sex education and prenatal counseling is the need of our antenatal care. During antenatal checkups, women has to be examined for HIV and syphilis twice during pregnancy to avoid missing the infection in the early trimester and also late trimester. If found infected, treat the same with appropriate measures and regular follow-up also to the partner Consider the steps to prevent parent to child transmission. Break the silence. Sexual activities are fundamental right to any individual. To keep the same as respectful and pleasurable forever is very essential. Sex education is very important, pertinent from school days onwards. Genital hygiene should be stressed in this sex education. Regular cleaning of genitals is necessary for happy and healthy sexual and reproductive life and forever in the future. Over enthusiastic deeds will worsen the situation, especially with regards to hygiene. And hypersensitivity, due to hypersensitivity, alteration of pH, normal flora, ecosystem, make it vulnerable for infection and other pathological things. Unnecessary obsession also is to be avoided. Avoid browsing Google and internal sites will complicate your problems. So sexual health is a must, has to be maintained properly forever for a happy, prolonged life. Thank you very much.
In the 10 minutes, sir. Okay.
Thank you so much, sir. Thank you so much. And it's a very brief and a wonderful display of the starhood of yours. Thank you so much, sir. Thank you. And it's a very brief and a lot of learning. Thank you so much.
Thank you, Astinar Star, as for creating awareness, because we human beings will tolerate the tragedies of earthquakes, tragedy. We can tolerate the tragedy of anything, but no human being can tolerate the tragedy of the bedroom. So, as a Astinar Stars, so now you all the faculty are Astinar Stars. We will share the Astinar Star slide to create the genital health awareness for healthy genitalia and healthy skin, body and mind, and subsequently healthy nation. So until the nation is healthy by the physical and mental as well as genital health, so we will not progress from developing into developed countries. So we request, please share your WhatsApp groups, keep as a FB or in different states to create the awareness on genital health. So now over to Sai, the quiz master, Dr. Sai Krishna.
Yeah, the slideshow can
the 1 minute. Srinivas, is it over? Time
is over.
Sir, no, sir. Till 45 seconds.
45 seconds. Yeah. Till 45 seconds is there.
Sorry, I finished earlier.
Bhushan sir, can you add any points? Bhushan Kumar sir. Or chairpersons, you can give your inputs.
Yeah, I think you have said everything. So I just give an overview of today's program. It has been wonderful on vaginal discharge, a lot of learning. A case-based discussion is always one of the best way to learn. And we had very classical cases presented and wonderfully discussed by paternities. This is followed by urethral discharge, very nice 20 questions from Ilangon sir. And I think wonderfully answered. A lot of inputs from Dr. Bhushan Kumar and many others. So I think this is wonderful. And finally, we had the genital health the Astinar star performance by Murugan sir. I think these are some of the topics. I think this is one topic which is not generally discussed in many platforms. Thank you, Dr. Bhumesh, and many others who are involved in bringing up this. I think this has been a wonderful program. I thank on behalf of myself and Brigadier Professor Sanjeev Vaishampayan sir for having us involved as chairpersons for this meeting. Sanjeev sir.
Yeah. Thanks a lot. As Dr. Manjunath has already said, the last topic, the genital health, usually is not discussed or a neglected topic. I don't know why, but we all must propagate this, especially for the colleges. So I'll request Dr. Bhumesh that these sort of topics we must take to various colleges and spread the awareness about the genital hygiene, because that is what is very important, which will lead to a, as sir said, happy marital life. So thanks a lot. And it has been really wonderful. Last 2 hours, we don't know how they passed. So therefore, thanks a lot. And all the PGs must have taken a lot from this discussion. Thank you.
One message. I take this opportunity to request all the faculties and postgraduates and professors who are not being already member in Iasstd, please become a member in Iasstd, and it will be valid. We will be improved, and PGs also will have a good chance to get so many knowledge. It will be a good profession, good hope for the future. So please become member in IAS, Indian Association for the Sexually Transmitted Disease and AIDS. Thank you very much.
Minimal qualification is MBBS, isn't it, sir?
Yes, sir.
To be
yes, sir. And we will send the membership form in the Iasstd and other platform. That is our Astinar 3 also. I will put the membership form. Please, all of you become members. Thank you, sir.
Mohan sir, can I have a request to you? Sir, I have not got my membership number yet.
Madam, there is a website, is there? Iasstd.
First, release the question key. Release the question key. The Srinivas.
Yes, sir.
Release. The quiz master will take up and he will read.
Please. Yeah. So the questions here are: to start the treatment of urethral discharge in a male, following tests are mandatory: gram stain, culture for gonococcal, both A and B, none of the above.
So answer is none of the above.
Yeah. The green one, which is displayed, is the answer. Drug of choice with dosage for acute gonococcal urethritis is cefotriaxone 250 mg. But yeah, presently CDC is recommending up to 500 mg. Following complications won't occur in male having urethral discharge. So these are one of the complications which does not occur is skinitis. Yes. Next. Contraindications for prosthetic massage. Of course, acute urethritis is a contraindication for prosthetic massage because of the painful condition. Next, follow-up of the patient with being treated for urethral discharge to rule out other STDs is up to 3 months. In trichomoniasis and gonococcal, co-infection, which is preferred treatment, which is the preferred treatment. Treatment with metronidazole followed by Grey or cefexime, which contains 400 milligrams of cefexime and
some barking sound. Please mute, please.
Just a second. Sorry. Motility of. I'll try to be more louder than that.
Quiz master. Go ahead.
Yeah, I'll try to be more louder than that. Motility of Trichomoniasis vaginalis organism can be defined as it's a twitching movement, which is true for Trichomonas vaginalis. Has 3 to 5 flagellae at the posterior end, has 2 nuclei, cyst form is ineffective, survive in ordinary hot water and chlorinated water. Yeah, the last one, survive in ordinary hot water and chlorinated water. The following is not true about metronidazole resistance in trichomoniasis. So expression of hydrogenosomal enzymes are upregulated. The following is not true. Next question. The following is not true about laboratory diagnosis of Trichomoniasis vaginalis. So here, Thayer-Martin medium is used in the culture of Trichomoniasis vaginalis is not true. In 60 years old woman is evaluated a 3 weeks history of vaginal discharge, describes the discharge as malodorous. She describes the discharge as malodorous, yellowish, accompanied by postcoital burning and dyspareunia. Her last Pap smear 2 years back was normal. On examination, there was a contact bleeding on speculum placements A web mount showed presence of organisms with twitching motility. The patient was treated with single dose of 2 grams metronidazole. Which of the following should be most appropriate additional intervention? So the most appropriate additional intervention would be to treat the patient sexual partner. Yes. Which is false about pseudoclude cells. So in the vaginal epithelial cells coated with Gardnerella vaginalis and other anaerobic bacteria. This is the false. Which is not true about Amsel's criteria. So where vaginal pH is less than 4.5. The following is not associated with bacterial vaginosis. Epidose is mandatory. So that is not mandatory. Recurrent bacterial vaginosis, which is true. If intrauterine device is present, its removal should be considered. So it is not necessary to remove the intrauterine device. Yes, the following is true about the point of care test in bacterial vaginosis. So BV blue test measures the sialidase activity. Bacterial vaginosis does not include profuse creamy discharge. Yes. Candida albicans can be differentiated from other species by unique ability to form which of the following in cornmeal agar? It's chlamydospores. Complicated VVC, vulvovaginal candidiasis, which is false. Oral fluconazole 150 mg for 3 days should be given in the first trimester of pregnancy. Yes, next. 56 years old women with uncontrolled diabetes presents in OPD with itching and cardivaginal discharge. Which of the following tests would help in diagnosis? Germ tube test. The color of the Candida albicans colonies in chrome agar is green in color. A woman with vulvovaginal candidiasis complains of pain and tenderness around the hymenal ring. The most probable diagnosis will be vestibulitis. So this was a lovely quiz and
results
for me also. Please, results. So the winner for the postgraduate results of postgraduate section, Dr. G. Satish Kumar from Madras Medical College. Congratulations. Dr. Yashasri Dungarwal from Usmania Medical College. Congratulations. And winner from senior residents, Dr. Prashanti from Government Medical College. Which place, please?
Suryapet.
Suryapet. Oh, congratulations. Congratulations to all the winners. I hand over it to Dr. Bhumesh.
Over to chairpersons. Thank you, Sai Krishna. So for nicely conducting the quiz. Though this time almost 10 questions are more. Generally, it will be 10 questions. This time it has been extended to 20 questions.
2 questions, and yes, it is really interesting questions, and I think I also should learn some more. Thank you.
Over to chairpersons to the vote of thanks. Invite vote of thanks, Dr. Mohan Kumar. Over to chairpersons.
Again, as we say, yeah, please. Yes. No, go ahead.
Yeah, may I invite Dr. Mohan Kumar. Thank you for spearheading the entire program of Astinar. So, yes, yeah, I invite you.
Yes, sir. Thank you, sir. On behalf of our Iasstd, we thank our chairpersons and senior faculty members, Brigadier Sanjeev sir and Professor Manjula Sai for their guidance and extensively summarizing the Astinar day of this March 20th, 2022. The first panel discussion by our faculty members, Professor Director Dr. Kalaimani Madam and other professors, Dr. Krina, Dr. Mahalakshmi Madam, Dr. Ilavadi Madam, and Kavita Madam and Bansal Madam for their expert panel discussion on management of vaginal discharges, which covers in depth in their issues. And the next panel discussion by my blood professors, Professor Ilangovan sir, and our senior professors like David S. Prasad sir, Anumandappa sir, and Dripsa sir, and our Bharathan Madam and Srinivas sir for the detailed analytic discussion on the urethral discharges in man, which covers not only urethral discharge along other anorectal discharge also. And we thank our Sai Krishna sir for excellent quiz, which involves more participation from our postgraduate students, and our excellent message on sexual health by our President sir, and as usual our mentor Bhushan sir to guide us in a better way for hoping this Astinar in a higher level. Once again, on behalf of our Iasstd, we thank all of the participants and postgraduate students for their active participation in today's meetings. Then, on behalf of our Iasstd, we thank our knowledge partner, Heterosexual Healthcare, and the team Astinar, that is the team Astinar Hyderabad 22, which led by our Professor Netha sir, Venkatamana sir, and Nasim Rao sir, along with our organizing secretary, Sir Bhumesh sir, for their commitment in making this academic event a great success. Once again, on behalf of our Iasstd, I request all the panel members to participate in Astinar Hyderabad 22, which comes on September 9th to 11th at Kataria Towers, Hyderabad, along with your postgraduates, and make it memorable. Thank you, Randall. See you in Hyderabad. Thank you.
And at the end, we thank all the delegates, almost 290 delegates, they have participated, and in spite of the busy schedule and the Sunday. So thank you very much for their participation and making this program a grand success. And thank you one and all. And with this, we'll close this Astinar 3. And the next month, third Sunday, I will come out with the Astinar 4 with another topic. Thank you very much. We will close this Astinar 3. Thank you. And before that, please join for one group photo.
3 cheers for Bhumesh.
Yeah. Yes, sir. Yes, sir.
Absolutely. Absolutely.
I thank Murugan sir and Kadagam sir for this nice opportunity.
Come out for group photo.
Yes, sir.
Thank you.
Thank you, sir.
I've shared all your Astinar star slides in the faculty. Please sensitize the genital health awareness.
Yes, yes.
Yes, sir.
Thanks a lot. Good night, all.
Thank you.
Good night.
Thank you, sir.
Bye, sir. Thank you, sir.
Thank you. Good night to
Good
all.
night, everyone.
Thank you. Good night. Good night.
Good night. Good night. Good night to all.
Good night.
Svetlana, madam.
She's gone, sir.
She left, huh?
Yes, sir, she's gone.
She was asking for membership.
I informed, sir. I informed her, sir.
Okay. Sure. Thank you. Good night.
Good day, sir.
Good night, sir. Murugan sir, good night.
Sir.
So it was really is very, very useful. Almost 2 panels and the sensitization Astinar, sir. Everything went on well.
Yes, sir. Thank you, sir. Thank you, sir.
Mohan.
Yes, madam. Thank you, madam. Thank you.
Alivan, madam. So
Yes, sir.
today we have seen your all Vishwarupam. So it is very good. So just almost this you have put everything in our mouth.
No, sir. Because
And congratulations for your team.
Yeah.
Your PG has got.
Yeah,
So
my PGS one.
that was your dream. That was your dream.
Definitely. Yeah, definitely, sir. Thank you for your.
Thanks to me
Madam,
also. My
Madam
SR has got.
Kalevani, one small suggestion.
Please.
Sometimes your voice is little low. You have to use some other mic or closer mic. Sometimes when compared to others.
Okay, sir.
Everything is good, very well, but small, sometimes your voice is going down.
Okay, well taken.
Thank you, madam. Thank you.
Thank you. Right. So Veeru and Srinivas, thank you very much for conducting the smooth flow.
Thank you, sir.
Yeah.
Welcome, sir. Good night, sir.
Yeah.
Good night.
మోషన్ రాసే